a co-host.
Great. We give it another couple of minutes to let people join, or shall we start? I think we'll start. I'd like to introduce Dr. Tadesse Mekonen, who is the Executive Director of Avacare Health. He's played a leadership role in successfully launching the Namibian HIV clinical mentoring program, and he has led all the preparatory work for and launch of the HIV test and treat pilot in Namibia, which includes development of implementation protocols, evaluation protocols, monitoring and evaluation frameworks, activity planning, and budgeting. He won the Young Investigators Award for Clinical Science Care and Treatment category at the International Conference on AIDS and STIs in Africa, ICASA, in 2015, for the work done in early pediatric HIV treatment, viral remission, and proviral DNA reversion. And he has successfully trained and coached clinical mentors across the country, supported the establishment of an adolescent-friendly health center for the HIV adolescents in Oshakati Intermediate Hospital, Namibia. And he has supported the strengthening of pediatric HIV care and treatment and pediatric HIV disclosure. Sorry, can we make sure that everyone's muted? Amongst many of his achievements, he has led the successful launching of the ECHO model of virtual training and mentoring in Namibia, with close technical and financial support from UNM, CDC, EGPAF, UW, and ITEC. This is the first ever ECHO launched on the African continent, and some African countries are showing interest to replicate the practice to their settings. For those of you who listened to his talk approximately a month ago, I'm sure we all have many questions to ask Dr. T. He's going to start by showing some of the slides from his previous presentation, and then we can kick off with a Q&A session. So welcome, Dr. T. The floor is yours.
Thank you very much, Dr. Jackson and the whole Intellectus team and Avacare Health Group. I hope you can hear me clearly.
We can hear you well.
Great. And can you see my slides? Not yet?
Yes. Oh, I can see your slides, but you're not in presentation mode yet.
Yes, I'm going to fix that now. I hope it is now in presentation mode. Yeah.
Yep.
Excellent. Excellent. Thank you. Thank you again, Team Intellectus Campus, Team Avacare, for presenting us with rare opportunities to bring us together to ensure a strong community of learning together to advance our healthcare on our mother continent. So thank you for that. For 150 plus colleagues across the Southern African countries, it is again an honor to speak to you today. In continuation to our discussion about a month ago, where we had so much information provided in a way of update from the IAS 2023 from Brisbane. Today, what I do is I will just summarize the presentation from last time in 3-4 slides to kickstart the discussion. Then we'll go into open question and answer sessions where we all participate together. There's no one who knows all the answers. So please feel free to ask all questions you have related to this previous presentation or the challenges we face every day in our HIV clinical care, or other things you may have. Also be prepared to answer some of the questions as well, especially when they come in relation to the context where you are working from. So in a way of a summary, the presentation was divided into 4 parts. The first one was updates on treatment. And the key studies and findings and change in guidelines were summarized as such that now for the first time, we are able to confidently say that people who have undetectable viral load for HIV have 0 chance of HIV transmission. This is very, very landmark. This is emanated from a very landmark systematic review published on The Lancet on 23rd July, the same day WHO released this guideline. And this is significant achievement for all of us who have been working in the field of HIV, caring for patients, and for all people, importantly, for all people living with the infection. The implication in terms of healthy living, the confidence that inspires in the healthy living for these people, and at the same time, the confidence that it inspires for public health policymakers and practitioners by virtually eliminating onward HIV transmission is also very colossal. Besides that, it is also very important to note that if we continue to achieve undetectable community-level viral load across all communities, we have now a tangible potential to eliminate HIV as a public health challenge and subsequently to eradicate it. Simply think of a circumstance whereby the inflow of water into a pool is closed, but the outflow is open. At some point, the pool will dry up. Basically, flow is an onward HIV transmission. The outflow is people who are dying, aging and dying, who have HIV infection, and the inflow is a new HIV infection. The moment we bring that to zero, then we will at some point eradicate HIV. So that was really, really very important. And another take home from this undetectable viral load is equal to zero transmission should also be taken as a responsibility for public health policymakers, clinical practitioners, medical aid schemes, and all stakeholders to ensure that there is readily available access for viral load monitoring. It is time we need to enhance. We have always been saying we need to enhance viral load monitoring, but it is time now that this should incentivize widely accessible, technologically appropriate, and highly sensitive viral load monitoring, including point of care and near point of care viral load monitoring in all our countries. We should all advocate for that. Another major finding presented from one of the trials was from dual therapy using dolutegravir and lamivudine, where patients who have M184V or I mutation, which is signature for 3TC or FTC, were included and given DTG and 3TC. The 48-week result in viral suppression was comparable between patients who have resistance to lamivudine or FTC, as compared to patients who had effective 3TC or FTC. In other words, dual therapy maintained successful viral suppression even when 3TC or lamivudine or emtricitabine was not working. So that was very, very intriguing result. Effectively, what we're saying is dolutegravir monotherapy can maintain successful viral suppression if it is supported by an emtricitabine mutant virus without emtricitabine having any antiviral activity. So very interesting finding, but we know this is not fully surprising because when patients have M184V mutation, that mutation by itself maintains pressure on viral multiplication, or the virus pays a fitness cost and multiplies slowly, giving the opportunity for the very robust dolutegravir to actually kill them fast. So that was one observation, but clearly adding further weight to the dual therapy, and we believe dual therapy will be part of our practice in some years to come. As always, Botswana is the leading light in introducing dolutegravir 3TC. We all feel some anxiety when it comes to dual therapy because we have learned in the hard way in early 2000s, in the 1990s, where resistance fast emerged. At least with the contemporary data, dual therapy with dolutegravir could be a good place to go. But again, widespread blind scale-up of a dual therapy
cardiovascular disease, although receiving a statin therapy.
Hello, when you're not speaking, can you kindly mute your mic, please? Thank you. So again, it's going to be a contentious issue, but there could be place for dual therapy, especially in patients who cannot tolerate the NRTI backbone. Another important study was also that studies that showed bictegravir, which is the latest generation integrase strand transfer inhibitor, containing antiretroviral therapy, achieved sufficient concentration during pregnancy and postpartum period with excellent efficacy in fully suppressed patients. As you all know, pregnant women and children often lag. Evidence from pregnant women and children often lag from the general population because of often unknown toxicity or safety profile of new agents. So we often learn about PK parameters and efficacy and other safety indications later after such drugs are approved, and bictegravir has not been tried in pregnant women. And this study was very important to show that. So bictegravir, we hope in the future will be approved in pregnant and breastfeeding women as well. Another very interesting study was that in patients who suppressed viral load while on HIV treatment, oral daily therapy, but had complex medical and social circumstances in Australia, when they were given long-acting cabotegravir with rilpivirine injections, they actually maintained successful viral suppression. And at the same time, they almost 90 to 93% of the times, they were adherent to their injection schedule within 7 days before or after the schedule. Again, this is very indicative of the fact that there is a good place, at least in some population at the moment, long-acting injectable antiretrovirals to avoid or to reduce the risk of poor adherence and selecting resistance to oral antiretrovirals. And interestingly, in that study, what was observed was that patients who were not in a stable relationship, patients who didn't disclose their HIV status, patients who are traveling often, including long-distance truck drivers, had better preference for long-acting cabotegravir and rilpivirine. So that speaks directly into the differentiated service delivery recommendations of the World Health Organization. We should provide services to our patients addressing their circumstances, their challenges, their difficulties, and also the particular situations they are in. So that was another very important study that was reported this year. The last one before the last was that, as you know, islatravir is the only drug in the class called nucleoside reverse transcription translocation inhibitor. Basically, reverse transcription translocation implies that every time when the virus multiplies, it has to reverse transcribe itself from RNA to proviral DNA, single-stranded, which then creates the complementary strand, become a double-stranded proviral DNA that gets into the nucleus and finds itself integrated into the host DNA, and then the protein synthesis for the virus continues at the demise of the host cell multiplication. So what islatravir does is, when the virus reverse transcribes itself, it reverse transcribes itself by putting in sequence of nucleotides. And then every time a nucleotide is put in there, it will be shifted distally like a bar of soap, a bar of soap manufacturing in a plant, in a manufacturing plant. So the pushing distally from the point of reverse transcription is called translocation. Otherwise, they occupy the place for the next nucleotide to be sequenced. So to be in the sequence. So this is a translocation inhibition, a very, very exciting molecule, which is strongly potent in nano-osmolar, in sub-nano-osmolar concentration. It has been tried for treatment. It is now being tried in the lab and in animal models for pre-exposure prophylaxis as well. So there were trials that were conducted with doravirine and islatravir. We had with 100 and 0.75 milligram dosing. Imagine 0.75 milligram is simply 75 microgram as compared to 100 milligrams of doravirine. This, as compared to a standard of care antiretroviral therapy, achieved successful viral suppression. Comparable. Safety profile with doravirine and islatravir was also comparable. This comparison was done with an integrase inhibitor with a dolutegravir containing regimen. And at the end, there was a significantly higher number of patients having lymphopenia, low level of lymphocyte count in patients who received islatravir. For the same reason, the islatravir study was halted by the Drug Safety Monitoring Board previously, reinstated, and the finding was similar. There was an increase in lymphopenia. But the researchers have defined that the level of lymphopenia was dose-dependent. The higher the dose of islatravir, the higher the risk of lymphopenia. For this reason now, a reduced dose of 0.25 milligram of islatravir is progressing to phase 3. And they feel confident that this would achieve sustained viral suppression with actually significantly reduced or non-significant increase in lymphopenia. Remember, lymphopenia is bad because that's all what we struggle to prevent by giving antiretroviral. So again, this was a very, very exciting finding, and we may have this combination to come into the picture to help us do away with the use of dolutegravir everywhere in first line, second line, and third line. So this was very, very exciting data that emerged. Hopefully, maybe by the next conference, we may hear some preliminary data how the 0.525 milligram islatravir, did actually in the phase 3 trial. We hope. Another very interesting, practically very relevant finding was from the advanced trial. In advanced trial, where they compared viral suppression and monitored for safety endpoints over the years in South Africa in 3 arms. One arm was TDF-efavirenz and TDF-efavirenz and emtricitabine. The second arm, TDF emtricitabine and dolutegravir, and the third arm, TAF, emtricitabine and dolutegravir. What they did in this report was that in all patients who failed virologically to either of these regimens, if we intensify adherence counseling, how many of them will suppress their viral load back? Very interestingly, they found out that over 48 months, 95% of patients who failed to dolutegravir containing regimen resuppressed the viral loads, as compared to close to 50% of patients who were actually on efavirenz containing regimen. So patients on efavirenz also suppressed really well. But patients who are on dolutegravir, even if they failed, they actually resuppressed the virus, which was a very, very important evidence. In other words, what that data was telling us was that, please do not rush to change to second line while your first line is working. Whenever we move to second line, we are actually losing more and more opportunities, more and more future possibilities for HIV treatment. So we're selecting away newer molecules. So it is really critical to keep in mind that we should not rush to change patients from first line to second line. 2/3 of the patients, I said 50%, sorry, I meant to say 66% of patients on efavirenz suppressed back. We know efavirenz has a low genetic barrier. One mutation can knock it out, but still resuppression is important. I think this is a very practical advice that emerged. So another section of our discussion last month was on adverse events. Again, another landmark study that was presented this year was the use of pitavastatin, which is a moderately acting lipid-lowering agent with some degree of immune preventing or reducing residual immune hyperactivation in patients with undetectable viral load. The purpose of this study was to see if and by how much pitavastatin provision reduced the risk of major cardiovascular events in people living with HIV and suppressed with ART. And the finding was very compelling that in these patients, there was a 35% reduction in viral suppression. 35% reduction in major adverse cardiovascular events in people who received pitavastatin as compared to patients who didn't receive. When they combined major adverse cardiovascular events with days, there was a 21% reduction in composite endpoint. So, and then there was no safety concerns around it. There was no drug-drug interaction concerns around this molecule. And then this, we strongly believe, will shape our practice such that patients who are on antiretrovirals could benefit from a supplementary statin given to them. An interesting observation in this study was also that patients who had higher risk of cardiovascular events actually benefited more. So it is important to make sure that we prioritize patients with higher risk of major cardiovascular events, including morbid obesity, hypertension, other risks of cardiovascular diseases, liver injury, and the like. So important. If you ask my opinion, it is high time already to indicate the use of statins, at least in the private sector, where you have the flexibility of using statins. And remember, the likes of pravastatin, atorvastatin are even more potent than pitavastatin, and they are available in our practice setting. Another observation that kept on giving more and more answer to our confusions from the years before was weight gain and integrase transferase inhibitors, especially dolutegravir. The findings reported from several studies this year were generally mixed. It was observed that patients who were given doravirine and islatravir didn't have a weight gain advantage as compared to dolutegravir. So islatravir is not likely to be a drug that we run to if weight gain is a problem with dolutegravir, even when islatravir gets approved in the practice setting. When patients were shifted from dolutegravir to darunavir-containing regimen boosted with cobicistat, again, there was no difference in weight gain observed. Another interesting study was when patients were switched to a bictegravir-containing antiretroviral and monitored followed over time. Both the bictegravir arm and the dolutegravir arm, there was an observation of general weight gain, but the analyzed weight gain was lower in patients who received bictegravir as compared to dolutegravir. So we need to cautiously interpret this. It's not like bictegravir has reduced the weight, but the rate at which the weight gain was slower than dolutegravir, which is good, even if it's a marginal advantage. Another growing evidence is around hypertension, high lipid level, dysregulated lipid levels, and treatment emergent hyperglycemia. From treatment emergent hypertension point of view, different studies from West Africa, NAMSAL, from Zimbabwe, from Newlands Clinic, even to some extent from Advanced Trial, and other studies showed that there was clear association of increased risk of hypertension after starting dolutegravir. So that is really, really very important to weigh in our practice. Last year, this time, there was data growing, but this year it is getting stronger. Probably more data will come. Always we weigh the benefit and risk of a certain molecule before global guideline changes are activated or triggered. But the evidence that has accrued so far is, I believe, in my opinion, instructive enough at least to consider to do a case-by-case clinical decision-making in patients who have risk of hypertension. and probably avoid dolutegravir in those patients, or when they develop hypertension, substitute with another drug which can maintain efficacy. I know making such change in the public sector is not easy, but at least clinical mentors, specialists can advise case-by-case clinical decision-making in the public space. And in the private sector, where there are flexibilities to advance clinical care earlier, I think we can use such information to advise our clinical decision. Again, not on a global scale, but on a case-by-case basis. And that's the benefit of evidence. Dyslipidemia was also interestingly higher in patients who received integrase strand transfer inhibitors, including dolutegravir, and it was shown to be higher in patients who took TAF together with dolutegravir. That is not a surprise, but isolated increase in dyslipidemia in patients who are taking dolutegravir was also, again, an interesting observation. Diabetes mellitus, again, treatment emergent hyperglycemia was evident and was associated with the use of dolutegravir, and that is another interesting observation. So quickly finishing off with prevention, I believe we'll have a long question and answer session. So I have hands raised from Prince. If it is a question, would you mind to hold until we finish? We'll be finishing in the next 5 minutes or so. Thank you. In terms of prevention, there was a study conducted in adults who are HIV negative, in terms of the preference for pre-exposure prophylaxis between long-acting cabotegravir and oral tenofovir disoproxil and emtricitabine. It was found out that 72% of patients preferred long-acting, and the reason being they gave different reasons, including that it is superior, the injection are longer apart between each other. And the side effects are not daily, and also disclosure issues and convenience. And interestingly, this injection of cabotegravir was done in the US and with non-medically licensed, trained community health workers, really bringing translation of the science into the public space, which speaks more to our setting. So cabotegravir can be effectively administered by community health workers as long as they are trained, coached, and mentored effectively. So that was very, very instructive. And the use of TAF with emtricitabine for PrEP was associated with treatment emergent dyslipidemia and hypertension, which is also another unfortunate observation, but we know that with TAF there is a risk of increased dyslipidemia. The hypertension part was interesting. Islatravir, as we talked about it earlier, it is now showing some promises in sustained release when it is formulated as an implant, a subcutaneous implant, but it's still in the lab study and in rats, but we hope it will progress to clinical development soon. The last slide, in terms of TB and HIV, it was demonstrated that 1 month daily isoniazid and rifampicin demonstrates similar efficacy to 3 months course of isoniazid and rifampicin when given once a day in people on ART, including TAF and dolutegravir, which was a good finding. So because the 3 months basically means there will be 12 doses of isoniazid and rifampicin because it's a weekly one. And the daily dose for 1 month means there are 30 doses. So there is a very good pharmacoeconomic or health economic advantage, as well as adherence, patient convenience, and also possibly adverse events related benefit to that. However, the durability of this regimen should be looked at in the longer term, because this is not a vaccine. We have seen that the effect of TB preventive therapy wanes over time. A question that we have never been able to answer was that how often should we repeat TB preventive therapy and how long we should give it. Integrase inhibitors based on antiretroviral regimen showed also high-level viral suppression tolerability in TB patients, which was another good thing for a setting where we work where TB and HIV are both highest in the world. That's a brief summary of what we discussed. Maybe let me give the floor back to you, Dr. Jackie, to facilitate the question and answer session. Thank you.
Thanks very much, Dr. T. That was a really good summary. If there's anybody who wants to ask a question and you put your hand down, can you re-raise your hand? Right, Dr. T, Dr. Landman wasn't able to make this evening's session, and she presented a patient to me who has gone, it's a 37-year-old female, and she has gone from a BMI of 21 to a BMI of 40 on DTG and TAF and 3TC. And the question she asked was, the patient walked in and said, I'm not taking this anymore. You have to change me to something else. So her question and my question would be, if you had a patient who had excessive weight gain and developed metabolic syndrome on DTG and TAF, what would you switch them to?
Yeah, thank you, Dr. Jackie, for that practical question. I really suggest that this case study is written up also. This is really important. It speaks of the problem we're facing. Definitely the ideal regimen, unless the patient is resistant to it, would be an efavirenz containing regimen with TDF, tenofovir disoproxil, and with emtricitabine or lamivudine. The advantage that it brings is basically it takes away dolutegravir. It wouldn't bring in TAF as well, which would have, which is also lipogenic. We don't believe it's lipogenic, but its lipid-lowering effect is very minimal because there's a very small dose of tenofovir in TAF as compared to the 300 milligram tenofovir in TDF. So efavirenz is not lipogenic. TDF is not lipogenic, or efavirenz is not significantly lipogenic, so it is much better than dolutegravir. TDF is actually having a strong lipid-lowering effect itself. That is a side effect, but we need it. And 3TC is lipid neutral, and also it will not have effect on weight gain. So efavirenz, TDF, and 3TC will be an ideal regimen for this patient unless there is a reason for contraindication. And if there is efavirenz 400, it's even much better to provide to this patient. I hope that addresses your question, Doc.
It does. Thank you very much. We have Travolta who's raised his hand. Can we unmute him, please, or can he unmute himself?
Thank you very much for the presentation. Mine is a follow-up question to Jackie's question. What has been your experience with reversibility of the weight gain when it has been caused by DTG, even after changing the regimen? Does it actually reverse the weight gain?
Travolta, I'm sure you are not John Travolta, right? You're just only Travolta. Thank you.
Yeah.
That's actually a very, very important question. I almost touched on it, extending to the previous answer. Interestingly, some studies didn't show remarkable reversal in weight gain. In some patients, there was a reversal, significant reversal in weight gain. In other patients, there was no reversal in weight gain. So that is on one side. So the findings are not really compelling in terms of reversal, but we'll see more and more data. Remember, this is being observed. Dolutegravir was even rolled out in 5-6 years, and still we need to get more and more data. But the main reason why you have to shift them from dolutegravir is not only the reversal in weight gain, but it is arresting the ongoing risk of weight gain, dyslipidemia, hypertension, and diabetes mellitus. If you continue to give these patients having already obesity to this level, imagine the more they are exposed to this drug, the more they are likely to develop the other comorbid states as well, including diabetes, and that will be heavily consequential. Probably what one can do is, at the time of switching away from dolutegravir, institute a very strong, consistent lifestyle modification, and also lipid-lowering therapy, such that the patients can actually achieve weight reduction as they go. But actual reversal, we have to learn more, and more findings are mixed at this moment. Over.
Thank you for that, Dr. T. Another question that came up, and the person isn't on the group, is they were talking about the M184B mutation and the fact that you mentioned last time that it puts pressure on the virus fitness. Can you elaborate more on the use of 3TC in any regime in terms of disabling the virus?
Yeah, thank you, Doc. Again, very important question. Let me expand a little bit on also the history of using 3TC in optimized background regimen, what we call OBR. Colleagues from Namibia and a few other countries around, when we're managing patients with multi-drug resistant HIV, you remember, we always do genotype, and based on the genotype findings, we score every mutation for each class of antiretrovirals. And then based on that score, we arrived at what we call a GSS, genotype susceptibility score. And genotype susceptibility score. So resistance is not all or none for every drug. For example, for dolutegravir, it won't be all or none. It will be incremental. But for emtricitabine or lamivudine, it is all or none. One mutation, M184V or I, is there, then the medicine is totally ineffective, zero activity. But remember, always we kept 3TC even in third-line therapy, we knowing that it doesn't have any activity. And the whole reason is, as mentioned earlier, the discussions, is whenever a virus gets resistant or selects mutation, not all mutations are beneficiary for the virus. Some of them make the virus weak. A smaller proportion of the mutations can make the virus even stronger, but they are not very well, a big number of or constituencies of mutations. But predominantly, a virus gets weaker when a mutation is selected. And characteristically, when the amino acid at codon 184 is changed from M to V or I, the patient gets very weak. It doesn't multiply fast. It will not multiply fast. It rather multiplies slowly, which we call a fitness cost. So imagine a virus that multiplies 1/3 at speed of another virus. The rate of multiplication is low, means it gives opportunity for another drug to hit the slowly multiplying the virus to eliminate it faster. In other words, there is no fast perpetuation of enemies. You have your enemy is multiplying or getting its militants slowly and slowly and slowly, so you can eliminate them with a fewer number of bullets or fewer number of soldiers or staff. So simply, M184V mutation is classically known to reduce the speed at which the virus multiplies. It does not multiply fast. It multiplies very slowly. Now, okay, the mutation is there. So why do we keep the 3TC? Why do we want to give it? The only way you can keep, you see, when we say there is resistance to 3TC, it doesn't mean that every virus in the community or in the pool of viruses in the patient are all 3TC resistant. Some of them could be 3TC resistant, others could be not resistant to 3TC. So if you take 3TC away, because the resistant virus multiplies smaller, it will be overcome by a virus that is not resistant to 3TC. So when you take out 3TC after several months down the line, and if you go and sample the viral population from the patient, most of the virus that patient will have will be the 3TC susceptible one, which is more aggressive. So to keep the mutant virus as a dominant population in the patient, you need to give 3TC. By eliminating the 3TC resistant susceptible ones, you give 3TC resistant ones, which make the virus is slowly multiplying and given the opportunity for the dolutegravir to kill them very fast and maintain viral suppression. I hope that makes sense to you. So there are two things. One is what the mutation does, makes the virus very weak to multiply. And number two, what addition of 3TC despite resistance does, which makes the resistant mutant virus to be a dominant population of the viral populations in the patient. So yeah, we shall and will always keep 3TC despite resistance in the regimen. Over to you, Doc.
Thank you, Dr. T. That was very clearly explained. So obviously the wild virus is much stronger than the resistant virus, and you want to keep the weak virus as the dominant virus. So thank you for that explanation. Dr. Agnes Katsitsira has raised her hand. Agnes, can you unmute yourself?
Yeah, thank you so much, Dr. Stone. Thank you, Doc, for the enlightening presentation. I'm actually enjoying the discussion. So I'd like to comment on the issue of the reversibility of DTG-based weight gain. So from my clinical experience so far, switching to other instances may help manage the weight gain, but it does not guarantee complete reversal. So while some individuals may experience a reduction in the weight gain after switching, others may not see a significant change. So the effects of switching medications can vary from person to person, and the recommendation is that weight management should be approached holistically with a combination of healthy lifestyle choices and the medical guidance. And it remains an important area of ongoing research to better understand the relationship between INSTIs and weight gain, as well as to develop more effective strategies for managing this side effect. Then I would also like to comment on the U equals U, which I believe personally that this is a groundbreaking scientific finding, which has not only revolutionized HIV prevention strategies, but has also helped reduce stigma and discrimination against people living with HIV. But the main challenge lies in ensuring that this message reaches all individuals, including healthcare providers and the general public, and it will help us to dispel any misconception and promote the acceptance of equals you. But having said that, we need to be mindful of the fact that an undetectable viral load does not protect against sexually transmitted diseases or unwanted pregnancies. So it is also crucial to educate and encourage people living with HIV to have open and honest communication with their sexual partners about their HIV status and engage in mutual consent and shared decision-making, even regarding contraceptive methods. So let's continue to educate people that HIV prevention is a shared responsibility and that everyone has a role to play in preventing the spread of the virus regardless of HIV status. And by promoting U equals U alongside the new prevention strategies that Doc has mentioned, such as the long-acting cabotegravir, can actually help us as we work towards reducing new infections and achieving an AIDS-free generation. Thank you so much. That's my contribution.
Excellent.
Thank you.
Excellent.
Agnes.
Yeah, thank you, Dr. Agnes. So heartwarming to hear such feedback from the practice. Just a couple of things. I fully agree with you. Just to say that I know when you said when you're changing patients from DTG to other integrase inhibitors, I believe you want to say from DTG to other non-integrase inhibitors. Changing to other integrase inhibitors will not bring really much change. Victagravir showed a bit advantage, but generally we should move away from integrase inhibitors. unless resistance. So let's keep that in mind. I agree with you with the holistic weight management. But remember, colleagues, even if there is no reversal in weight gain, remember you are arresting or limiting the ongoing risk of weight gain and hypertension and diabetes and dyslipidemia. So there would be merit in taking these patients off from DTG while managing their weight. Again, I fully agree with you on, U is equal to 0 transmission does not guarantee prevention of other STIs. It might actually fuel up the risk of acquiring incident STIs if people start to get relaxed. Now, I am undetectable. Even if I do unprotected sex, I will not pass HIV, but get STI, and STI can increase the risk of HIV transmission as well. So this message should be crafted so carefully that it won't mislead patients and community advocacy groups as well. Really great points, Dr. Agnes. Thank you. Over to you, Dr. Jackie.
Thank you, Dr. T. I can't see anyone else's hand up. There has been another comment made that we need African solutions for African problems. And we know that Black females are more likely to gain weight on DTG and TAF. So one of the questions is that should we actually develop our own forum where we develop our own guidelines? And because DTG and the integrase inhibitors bring down the viral load so quickly, should we be doing a viral load pre-treatment 2 months later and then switching to an efavirenz 400 regime as maintenance? And I'd like to hear your thoughts on that.
Yeah, this is the most difficult question, Doc, because there are so many parameters we need to look at. So depending on the parameters, then the clinical decision can make sense. For example, if these are women with, I think one of the very smart points you mentioned is that we do baseline viral load. They have very high viral load. We know dolutegravir will benefit in robust, fast viral suppression. Then we get the virus suppressed, keep it at bay, and then put efavirenz. So that starting with dolutegravir is very important, so that we are in agreement. Now, the next thing is, if we give efavirenz, what will happen? The problem with efavirenz is as much as it is a very good drug, we're not throwing it away now. It has actually, most of the countries in Southern Africa and East Africa that have achieved 90-90-90 goals with durable community level viral suppression at 90% were due to efavirenz, not with DTG. So efavirenz did really very well if all the other medicines work together with it. But the problem comes when the patient messes around treatment and the viral load starts to go up. Then the risk of developing resistance is much higher than dolutegravir. That's where the fear is. So at a population level, at a public health level, putting efavirenz while there is dolutegravir at this moment, at least, is not justified. However, on a risk weight level, if we measure the risk of a patient developing hypertension, risk of a patients in pre-diabetes, patients with dyslipidemia, patients who have fast trend of weight gain, moving away from dolutegravir is justified. So exactly as you said, if we are able to change our guidelines to provide these provisions in the guideline, giving the flexibility for our practitioners to alter from DTG to efavirenz, it would be good. But making it at a global scale or at overall public health setting will be difficult because of resistance. But there is significant place for the use of non-DTG regimen, primarily efavirenz 400, in women and men who have all these risks, including morbid obesity. I hope that addresses it. But now, with available data, I strongly believe that there is enough evidence to include this in a guideline to advise, summarizing it, to advise practitioners to identify XYZ risks, which are obesity, dyslipidemia, hypertension, diabetes mellitus, and then consider changing patients from dolutegravir to efavirenz, and in that case, efavirenz 400. It is justified, even if we can't do it as a preferred regimen overall at the population level. Over to you, Doc.
Right, thank you, Dr. T. And I think the world is moving towards individualized medicine. We need to take each patient as an individual rather than try and apply a single algorithm to a genetically very diverse population. So I can't see any other hands up. Are there any other questions?
And we can do things about them, right? Yes. So, oh, you're so I like that. Tamaru has steatocystomas.
Any other comments, Dr. T?
Yeah, thank you, Dr. Jackie. Colleagues, it can also be comments, case studies from your teams. We'll be very glad to hear from you. Dr. Jackie, you touched on a very, very important point at the end when you said individualized healthcare. And individualized HIV care on the same token. Partly the challenge in Africa was that we followed a kind of communist approach in HIV management because we have never had enough specialized healthcare task force to critically look into different developments and differentiate decisions, clinical decisions. But we are slowly getting into that space. As you all remember, WHO released a guideline, I think 2016 or 17, on DSD, differentiated service delivery. That speaks to exactly what Prof. Dr. Jackie said earlier on. Differentiate the services, speaking towards the patient preference, choices, circumstances, comorbid conditions and the like. So that is opportune now to do that. Also, we have more and more choices coming in the basket. So it should also give us the opportunity to address the risk of our patients. The public health approach in Africa will remain, but with gradual differentiation, but at least in the private sector and in big centers in our countries, we should seize the opportunity to address the needs of our patients because they are human beings with different genetic makeup, different medical conditions, different preferences, and we really need to address that. So I just wanted to further strengthen or support to what you said, Dr. Jackie. It is very important and it's very high time to look at the individual differences of our patients and address their needs accordingly. Over to you. And from my end, thank you very much. If there is no further question, it's always lovely to speak to you, to learn from you, and to share also a little what we have. Thank you, Intellectus Campus. Thank you, Avacare Health Group and colleagues. We hope we meet again soon. Over to you, Dr. Jackie.
Thank you very much, Dr. T. I was one of our HIV colleagues is Dr. Landman, and we were discussing today what the best combination is: evidence-based medicine, algorithm-based medicine, or experience-based medicine. And I think a combination of all of the above probably is the way to go. And we've got to be careful not to lean too far into any of them, because the best possible outcome from a patient's perspective is a combination of the best available evidence, the experience of the clinical team, and I do think that African doctors underestimate how knowledgeable they are in infectious disease. And I think the last 3 years have shown us that Africa can lead the way. And I think we have to be very careful with algorithm-based medicine because it allows us to be replaced by anything that can follow an algorithm, which includes artificial intelligence. So I think we need to celebrate the fact that as African doctors or doctors who are practicing in Africa, we have an enormous amount of experience compared to the rest of the world, and we shouldn't underestimate that. So on that point, if there are no further questions, we've got 5 minutes left. Does anybody want to comment any further? Agnes, I may throw you under the bus and put you on the spot.
Yeah, thank you, Dr. Stone. I learned a lot from this session. I like what you said about the differentiated service delivery, because as a program, we've moved away from the one size fits all. We are now trying to tailor care to meet the specific needs and preferences of individuals living with HIV, and to ensure that they receive the right care, the right time, in the right place. And we've seen that by implementing differentiated service delivery, our healthcare systems can actually optimize resources. It can also reduce the burdens on healthcare facilities and empower patients to actively engage and be involved in their own care. I learned a lot from this session. Thank you so much.
Thank you, Agnes. And uncharacteristically, we are not going to run 15 minutes over time. So if we have no further questions, Belle, should we close the session?
Yes, Dr. Jackie, just wanted you to announce next week's presentation.
So I haven't got it in front of me right now, but it's Dr. Enos Moyle from recollection, and we are going to be discussing the long-acting extended delivery systems for pre-exposure prophylaxis. So we look forward to that. I think the long-acting medications are going to be a bit of a game changer, and certainly from Dr. Landman's perspective, she's very much looking forward to them being approved, not just for pre-exposure prophylaxis, but also particularly for treatment. So next week, same time, and we will have the Namibians on the platform in a week's time.
All right, thank you, Dr. Jackie. Thank you so much for attending. Thank you once again, Dr. T. We really can't thank you enough for taking the time to put together this presentation. Just a gentle reminder that everyone should sign the attendance register before you exit the meeting. We cannot add names to the register after the meeting has come to a close. So please make sure you click on the link and complete the register. For those that have not received their certificates, please note that it takes us about 2 weeks to issue certificates following the event. But if you've not received certificates despite completing the register accurately, please reach out to me with your details and I'll check what the issue is. It could be that the email address you included is, maybe it has an error in it, and then we'll issue your certificate. We'll check our registers, pick up your name and reissue the certificate. Thank you once again for participating.
Thank you, Belle, and good night, everybody, and have a wonderful evening.